So today we're going to be talking about the practice of pre-hospital transcutaneous pacing in the United States. And so all the data presented in this presentation was both presented as an oral abstract at NEMSP last year, and since then it's been published in the journal Pre-Hospital Emergency Care. So what do we know about transcutaneous pacing, right? We know it's a first-line treatment for bradycardia that's causing hemodynamic instability. We know that it's a rare procedure, and it's been studied repeatedly in the context of bradyasystolic out-of-hospital cardiac arrest and found to be largely ineffective for this patient population. So there's multiple randomized controlled trials out there that tell us that. But we really don't have a lot of data on kind of the population this therapy is applied to today, right? Like the outcomes of patients that receive transcutaneous pacing for bradycardia that's causing hemodynamic instability outside the context of cardiac arrest. And so our group wanted to address this question using the nationwide ESO datasets. And so we really had three questions that we wanted answered. So we wanted to know who's getting transcutaneous pacing in the pre-hospital setting. So what does this patient population look like? We also wanted to understand what are the outcomes of these patients. And then finally, we wanted to understand factors associated with pacing failure. At least in our experience, a large proportion of these patients, after pacing is attempted, they continue to deteriorate and experience cardiac arrest. And so we wanted to identify some factors associated with treatment failure. So again, we started with the ESO Data Collaborative, right? So for any newcomers that aren't familiar with ESO, it's basically a software company that provides electronic health records to EMS agencies all across the United States. And providers put all sorts of data into this EHR, right? Demographics, clinical characteristics, and then about 1 in 5 transported patients included in this data set, they have hospital disposition data. And so we started off with basically every encounter in this data set, which was over 30 million patient records. And then we trimmed those down to patients who received transcutaneous pacing following a 911 call. We also excluded patients who didn't have a transcutaneous pacing time documented and patients who had a cardiac arrest without a CPR start time. And we did that because we wanted to sort our cohort into 3 different groups. And so these groups are patients who basically were rescued by transcutaneous pacing. So they had the therapy applied and then did not receive CPR in the pre-hospital setting. The other group was that kind of failure group I mentioned, right? So the patients who have pacing applied and then deteriorate into cardiac arrest prior to hospital arrival. And then finally, and this is a pretty sizable chunk of patients who receive transcutaneous pacing, is those post-ROSC patients, right? So you resuscitate them and then they experience bradycardia that requires pacing. Now, the reason we wanted to kind of stratify our cohort into these 3 groups is I think it's pretty obvious, right? Especially for the patients who experience cardiac arrest, these 3 groups are going to experience very different outcomes, right? So we wanted to report them in a stratified manner. And so in terms of the outcomes we were interested in survival to hospital discharge. So for that subset of patients that had hospital disposition data, that was an outcome we were interested in. And then we were also interested in failure, right? And so as I said before, we define that as patients who had not experienced a cardiac arrest at the time of therapy initiation, who subsequently had a cardiac arrest that required CPR. And we explored the association between a number of clinical variables and these outcomes using multivariable logistic regression. All of our models were adjusted for age and sex. And then we performed a set of sequential models where we added in weight, provider impression, and then a series of vital signs. So in terms of our results and who actually received transcutaneous pacing, what we found was it looked like a pretty standard population in terms of elderly patients who experience cardiovascular emergencies. So the mean age was close to 70, slightly more males than females, particularly in the groups where cardiac arrests occurred in the pre-hospital setting. And then in addition, an interesting finding whenever we looked at the primary impression that EMS providers documented, we saw all the things that we would kind of have expected, right? Cardiac arrhythmia, altered mental status, cardiac arrest in the groups where that occurred. But interestingly, in the top 3 primary impressions, respiratory distress made an appearance. And so, that's important, and we'll talk about that in a little bit. Okay, so for the second part of our results, we were interested in, what are the outcomes of these patient groups? So for the group of patients that did not require pre-hospital CPR, Still, about 1 in 3 of these patients died prior to hospital discharge. As for those patients who experienced pre-hospital treatment failure and had a cardiac arrest following attempted pacing, about 87% died. And then for that post-ROSC pacing cohort, 91% of those patients died prior to discharge. Now, when we pooled, so we looked at all of the patients who had a pulse and had not yet experienced a cardiac arrest when transcutaneous pacing was attempted, we found that 1 in 5 of those patients required CPR prior to hospital arrival, right? So when you get to a patient, they're bradycardic, they still have a pulse, you're going to be doing CPR on 1 in 5 of those patients prior to hospital arrival, which is a pretty startling failure rate, right? And so then we went on and we explored, what are the factors that are associated with failure, right? With the hope that we could kind of get some clues onto maybe how to better deliver this therapy. And so we had a couple interesting findings. So we found that body weight was associated with pacing failure. So if you weighed more than 100 kilos versus 60 to 100 kilos, you were at higher risk of pacing failure. We also found a dose-dependent relationship between peripheral oxygen saturation and failure. So in comparison to the reference group of patients who had a lowest SpO2 greater than 90%, if you had a lowest SpO2 between 80 and 90, you were 2.8 times as likely, your odds of failure were 2.8 times as high. And then if you had the lowest SpO2 less than 80%, your odds of failure were 6 times as high. Kind of similar, like, looking at the respiratory failure picture. So for patients who had a primary impression of respiratory distress versus all those other primary impressions that we discussed, right? Altered mental status, arrhythmia, et cetera, you were 6 times or almost 7 times as likely to experience failure. Looking at another vital sign, we also found that a lowest pre-pacing heart rate of greater than 50 versus less than 40 beats per minute was associated with failure. So basically a non-bradycardic pre-pacing heart rate was associated with failure, right? And so the question is, what does this tell us about the practice of transcutaneous pacing? And so we'll start with body weight, right? And so this isn't really a modifiable factor in the pre-hospital setting, right? We can't modify our patient's body weight, but it suggests that pacing failure might be related to transthoracic impedance, right? People who weigh more typically have more adipose tissue, thicker chest walls, and that might lead to impaired current delivery and decreased capture and increased pacing failure, right? And so what do we do about this? The literature tells us that maybe pad position plays a role. So there was an excellent randomized controlled trial that suggests that if you switch from AL positioning to AP positioning, right, kind of decreasing that transthoracic impedance, you go from 40% capture to 80% capture, right? And so maybe pad positioning is a measure we can take, not only in our obese patients, but patients who have increased transthoracic impedance because of things like, respiratory diseases, COPD, et cetera. And then we have all these vital signs that are associated with outcome, right? So low SpO2, respiratory distress, and we'll kind of lump that together as respiratory failure, and then that non-bradycardic pre-pacing heart rate, right? And so I think the best way to illustrate this would be with a case study, right? So let's say you're an EMS provider, you respond to a call for respiratory distress, you get there, the guy with a history of COPD, he's clearly experiencing an exacerbation, right? He has a SpO2 of 60%, heart rate 112, he's normotensive. And then as you're treating him, right, you're treating him with, oxygen and you're giving him some bronchodilators. Minutes later, you look back at the monitor. He still has an SpO2 of 60%, but now his heart rate's 42 and your blood pressure cuff just threw out some question marks, right? And so in this case, I think it's pretty clear that this patient's probably experiencing bradycardia because of hypoxia, right? The bradycardia is secondary to hypoxia. And so in this case, jumping to transcutaneous pacing and flogging this patient's heart with electricity probably isn't the solution, right? And so maybe what we're seeing here, right, the signal of respiratory failure being associated with pacing failure is just pacing being applied inappropriately to patient populations that, this therapy really isn't designed to treat, right? This guy needs aggressive airway management. He doesn't need electricity delivered to his heart, right? Same with a non-bradycardic pre-pacing heart rate, right? Bradycardia is kind of the end stage of many pathways to death, right? If you're hemorrhaging, right, once you hemorrhage enough, eventually you're going to brady down to asystole and die, right? If you're in septic shock, eventually you're going to brady down to asystole and die once your shock has progressed far enough, right? So for those patients that start out tachycardic and then their heart rate declines to bradycardia prior to pacing initiation, again, maybe we shouldn't be applying pacing to those patient populations, and we should be prioritizing the management of their shock or the management of their respiratory failure, right? Which is something that we can address in training our paramedics to perform this procedure. Another facet of this that's kind of recently been highlighted in the literature is the role of false electrical capture, right? So kind of ECG changes that are induced by transcutaneous pacing in the absence of mechanical capture. This was recently actually addressed on this webinar by Josh Cambrell and Judah Kreinbuch and others who published a case series recently in pre-hospital emergency care. The role of this in pacing is being further explored. So actually, our group at WVU is coordinating a multi-center study with a number of other sites to study this phenomenon, establish its incidence, look at outcomes associated with false electrical capture, and that study is currently ongoing. So in conclusion, transcutaneous pacing is an uncommon procedure associated with a high mortality rate. Failure and subsequent cardiac arrest is extremely common in the pre-hospital setting, and we were able to identify some factors including increased body weight, hypoxemia, and a non-bradycardic pre-pacing heart rate that are associated with progression to cardiac arrest and failure. So yeah, thank you all very much for listening, and I'm happy for any questions or commentary that you have to provide.
Oh, okay, got it. It's unmuted. Thanks very much. Good job, Tanner. I'm sorry, I was supposed to introduce you, and I don't know if we got the CME number out there today, 19435. Okay.
I
Thanks.
did put it in the chat.
For some reason, I was was muted when I was trying to do the introduction for you, but thank you for doing that for us today. So I just wanted to make sure you got that message. You didn't know. I didn't mean to let you down.
Yeah, no worries.
So, okay, let's see if do you have any questions? Let's look at what's in the chat. Is there any questions for you there?
Not so far. I don't see any hands raised or anything so far. Feel free to put a question in the chat, shout it out.
Now, were there different, let me ask you this, were there different pacemaker types, or is there just one out there? Or, I know there's not, but I mean, just saying, we're able to break it down according to the different, let's say, brands or whatever you want to call it, people who make them, manufacturers. And did you notice any differences there?
Yeah, so that's definitely a very important area of future investigation, right? Because, similar to defibrillation, it's possible that, the way that these different devices deliver current is important. In this data set, right, so we used ESO for this. So we didn't have any waveform data. We weren't able to determine if it was a LifePak or a Zoll monitor that was used. But so our future, the multi-center trial multi-center observational study that we're currently enrolling patients in, we'll be able to look at variables like what monitor was used, and we'll have continuous waveform data to get some more granularity.
Yeah, I mean, I suspect that you'll see some differences there, and it'll be really cool to delineate those. Unlike AEDs that for the most part are now pretty standardized, et cetera, in terms of how they operate, these are a little different. And so that'll be, so I hope you do break it down and stratify accordingly. So.
Yeah, absolutely.
Okay.
Larry McCarter says it sounds like AP placement of pads should be considered for all. I think that's definitely, again, there's randomized data out there. The highest level of evidence suggests that that's probably the best move. So I would agree with that. And then in terms of a link to the study, I'll see if I'll put that in the chat as well.
And I just like the fact that you're emphasizing that, when you have people that you think, well, we got to pace them, a large part of that is, is exactly right. It's the underlying problem that you got to fix, like the hypoxemia or the lack of perfusion, if it's a trauma patient bleeding out, et cetera. So that's a really important aspect to get on top of. Now, having said that, that also it may be too late in some of these cases too. So that's the other issue you might want to look at, is to see, the timing to this, et cetera, especially with regard to other. So it's a lot of multifactorial things happening all at once under these circumstances. So.
Yeah, especially for that post-Ross cohort. I mean, that made up a significant chunk of our sample. And so, for future studies, I mean, these patients rearrest for all sorts of reasons, right? And there's a number of disease processes at play for this. It's a heterogeneous population. I'll put it that way.
Yeah, right. Okay, well, if we have, there's Sam. Go ahead. What's he have to say in the chat?
Yeah, so he talks about assessment of perfusion using end-tidal CO2. Yeah, and so I think that, just in general, multimodal confirmation of mechanical capture is important, right? We should be, trying to get a pleth wave with our pulse oximeter. We should be trending end-tidal CO2 values. If you have ultrasound, right, that's probably the gold standard way that you can actually confirm that you have mechanical capture. At this point in time, there isn't a paper I can point to that says that those are reliable markers of mechanical capture, right? Like end-tidal CO2 and kind of synchronization of the pleth wave, right? There's no data out there now, but those are kind of pre-specified aims of that multi-center study that I discussed before. So I suspect that end-tidal CO2 might not be as useful just because of how noisy that data can sometimes be, especially because many of these patients, particularly the patients not in cardiac arrest, do not have advanced airway management. And so they're just using kind of the nasal prongs, which, there can be a lot of variability there based on if you're running oxygen through them, at what rate, if it's positioned correctly in the nose, if that little kind of reservoir is positioned over the mouth. But again, it's a tool in our toolbox. I think it should be deployed on these patients, right? We should be super aggressive about throwing every monitoring modality to make sure that we're actually pacing these people, right? Yeah, excellent comment. Yeah, and I put the link to the article in the chat. So yeah, so Mr. Zalkin said the basics, you need to be able to palpate a pulse. I think sometimes that might be easier said than done in a lot of these patients, right? I think that the literature shows that we're sort of unreliable at being able to accurately palpate pulses, especially when it comes to the kind of the contraction of thoracic muscles, right? Definitely don't go for the carotid. Even the radial, I think, is suspect. There's been some suggestion, at least in a case series, that the transcutaneous pacing can actually induce kind of a pseudopulsatile flow that can even change the pleth waveform that we're getting, right? So if you're going to palpate a pulse, definitely go for the femoral site. But again, and I've seen during some calls, right? It takes a while sometimes for people to agree if they have a pulse and if it's at the appropriate rate. So definitely a limitation. Tim Ryan is asking, is there any use in increasing milliamps with larger patients? Again, I don't have any data to suggest that higher milliamps is better. I would assume that in the setting of increased kind of transthoracic impedance, that increasing milliamps would lead to more effective capture. Again, there's not a lot of data in this space. We need a lot more research on the practice of transcutaneous pacing, which I think, a lot of these questions illustrate. Luke, you have your hand raised. Go ahead.
Yeah, hi, Tanner. Three things. One, did you have any way to check what the confirmation method was that these patients were actually paced, or were they pseudo-paced, and maybe that contributed to the downfall?
No, that's an excellent point. We had no way to confirm, what method was used, right? We didn't have access to any free text fields, right? So we weren't able to see if people, what site they palpated the pulse at, if they even documented mechanical capture, right? So for some of these people, right, providers could have known that pacing was unsuccessful, right? They could have been dialing up the milliamps to the maximum that their device allowed them and just still not getting capture. So again, kind of using this registry data from ESO does have its limitations, and that's definitely one of them, right? We definitely miss out on some granularity in terms of kind of the practice patterns for confirming mechanical capture. But I promise it's going to be addressed in our upcoming observational study.
Okay, I don't remember most of them, but my last patient I paced who was in an idioventricular rhythm, unconscious, hypotensive, I knew I had capture because I got 60 OPMs, hours per minute, until I sedated her. So that was a pretty reliable that we had capture.
Yeah.
The other one is for you and Dr. Pepe. We've talked about epi, either drip or push dose post cardiac arrest, as a kind of prophylactic means. Do you think, and this is a surmise, it's not part of your study, that might make a better difference than, if that's a word, than pacing afterwards?
Yeah, so and just to make sure that I'm understanding your question right. So in terms of either adding on or starting with pharmacologic therapy, right? So like an epi drip, like you're saying, are you asking, do you think that's a strategy that should be pursued?
Right. Well, we've talked about it in some of the webinars that routinely the possibility, instead of pacing post arrest, we get ROSC, we've given epi, it's going to wear off. Should we start a drip, a push dose, and would that help alleviate what's been happening afterwards with your cardiac arrest post pacing?
Right. Yeah. So I think again, I will disclaimer. I don't think there's any necessarily good evidence to say that would impact outcomes. But I think it definitely has the possibility, even in that post-rest patient, to eliminate the need to even go to pacing, right? If you get ahead of it and start supporting their hemodynamics with, some of the beta effects of epinephrine as well. So. Yeah, I think it's a reasonable strategy to pursue, right? And you know, we know that 40% of post-arrest patients are going to become hypotensive in the pre-hospital setting and require hemodynamic support. So yeah, I think it's an excellent strategy to have that vasopressor drip running and then just titrate it down or up as needed. Could get around some of these the high
and that's
incidence.
kind of my point, that you're getting alpha and beta, which can both be helpful in that post-arrest situation. If I can bypass your bit, Dr. Pepe, can you weigh in on that, please?
I just had to find the mute button here, right? So first of all, it's not a binary answer like yes or no. It depends on the situation a little bit, etc. And so I'm sorry, I'm getting all these texts at the last minute here. Sorry about that. Anyways, but let me just think, what's the utility of it? One of the things that people do if they have an idioventricular rhythm or they got a systole or whatever it might be, it probably represents they were down for a while in most cases, not always, but generally will. And so what happens during cardiac arrest, what people don't really appreciate too much is that because you have such a low perfusion state, you're not getting a lot of blood flow out to the tissues, et cetera. What's happening is you're getting progressive vascular relaxation. So right now you have a blood pressure because you have vascular tone. And so if you suddenly don't have oxygen going out there, you're going to start losing a lot of that vascular tone. And so as a result, even if your heart was beating really well, it's beating out against, loose pipes as opposed to tighter pipes that would give you the coronary perfusion that you want, at the end of the day, so to speak. So part of the rationale for doing that epinephrine is to actually tighten up the pipes a little bit, hopefully, if it's not too far along. That's what I'm saying. It could be too far along. And you attempt to do it. And I like the idea of the drip largely because in the old days, we give a push, you get a boost, you get a push, you get pulses back, you go, wow, that's cool. And then what happens, it wears off and then it just kind of crashes and it's harder to get them back on that end. But so there is some rationale, but you can't, you got to be careful. There's the issue that are you irritating the myocardium even further with beta effects if it's a VFib case. But if we're talking about a lot of these cases that are, idioventricular, if they're whatever, I think it's worth a try. The secondary rationale for doing that is that you could get that set up hopefully a lot sooner than you can get some of the pacing stuff set up. That's the other thought there as well, right?
Thank you.
Oh yeah, and just one last part is that maybe if you do get some reperfusion, if you get to them in time, or you can get some better coronary perfusion, you may be more responsive as a result to the pacing if it's a hypoxic heart or whatever, or underperfused heart. Okay.
Makes sense. And I agree with you on the drip. The steady state is probably going to be better than the intermittent pushing.
Well, and everybody got the CME for today then. What was it, 194.35? And then I got to switch over to the other meeting here pretty soon. Any other questions or anything else that you want to talk about? Okay. Well, if not, thank you very much. I'm going to head over to the other show. Thank you all for being here today. I hope that was helpful to you. So thank you, Tanner. All right. So we'll see you on the other end.
The link to Dr. Pepe's webinar is in the chat.
We're going to talk about more boring stuff today. So you'll see. All right. See you. Take care.
Thank you all.
Bye-bye.